Thank you. I'd like to thank Dr. Saklamaki for inviting me and her whole team for supporting my trip over here. This is the 4th time I've had the privilege of coming to the ΜΗΤΕΡΑ. The first time for one of these anniversary celebrations, so it's quite exciting. Oh, I'm not loud enough. No one ever says that. So it's quite a privilege, and it's also quite an honor to see so many of you here, so many familiar faces that I've met over the years. And it's also the first time I've had the privilege of being in Greece with one of my mentors, Dr. Delaboria. So a lot of firsts for me today. Today, I'd like to talk about non-invasive ventilation in neonates. You'll notice the title says with RDS. But we've already heard very elegantly from Dr. Spear, there is a pathway for management of RDS. And we've already heard very impressively from Dr. Saklamaki that the outcomes here for infants with RDS are exceptional. So what I'd like to talk a little bit more about is a little bit of an overview of what is the real point of what we're doing for premature neonates with respiratory diseases. So the first time I came in 2010, we globally talked about some of the preclinical trials on minimally invasive ventilation in the neonate that I participated in. In 2012, we talked about challenges in ventilating these babies mechanically. In 2015, we had more emerging therapies in non-invasive ventilation for neonates that were becoming increasingly the standard of care. A lot of tools in the toolbox, but one real goal, improving the long-term outcome. How can we reduce BPD and chronic lung disease? Whether or not you believe that they're different disorders or all on the same continuum. So when we talk about BPD, how do we characterize it? What are the numbers? Are the tools we're using successful? And how can we determine if what we're doing is really the optimal treatment for our patients? So you cannot be in Athens and not give a little bit of history. BPD was first characterized in 1967 by Northway et al., a syndrome of severe lung injury in preterm infants receiving mechanical ventilation and high levels of inspired oxygen. Everyone in this audience knows that. What was interesting for me to pull the source document and realize those babies were huge. 2.3 kilograms in 34 weeks. That is a very large preterm baby. Those aren't the babies that are in our nurseries in this day and age getting BPD. Those are babies that are staying for a short period of time and actually doing quite well. So it was a very different disease. It was characterized by very prominent airway injury, epithelial metaplasia, smooth muscle hypertrophy, and then fibrotic areas and emphysematous areas. The predominant focus was on mechanical ventilation and oxygen with an apparent cause and effect. It does seem that there is a cause and effect there, but again, it's not necessarily the disease we're seeing in 2019. The pathophysiology of it was impacted by lung immaturity and an imbalance of enzymes and enzyme inactivators, of proteases and oxidants and antioxidants. Oxygen was definitely demonstrated to be toxic, and mechanical ventilation had a number of impacts, whether it was labeled as barotrauma, volutrauma, or the atelectotrauma. Areas of overdistension and underinflation were really what the issue became, leading to fibrotic changes. And in its worst case scenario, this is taken from one of the earliest manuscripts, very late stage BPD, or chronic lung disease as it was then called. And you can see the hyperinflation at the bases and the atelectatic pockets. But that's not what we see. We see new BPD. And actually, since it was described in 1999, maybe it's not so new BPD. But it was really more characterized by an arrest of lung development. These are much smaller, extremely low birth weight infants. They're not super sick when they're first born. They sneak up on you. Their lungs are hazy on day 3 to 5. By day 7, they're going up a little on oxygen, a little more, a little more. They have very minimal emphysematous changes, but they can have some mild hyperinflation. Their oxygen requirements don't go away, but they're never very high. Their airways are less reactive. and they have less early pulmonary hypertension, although there's enough growing evidence saying that it presents later and maybe is much worse when it does present. So this gives you a little sense of the timeline and probably clarifies quite quickly why we're seeing more of this now. As we look at your outcomes at the ΜΗΤΕΡΑ and we see what excellent survival you have for 23 to 28 weekers, it makes more sense that more of these babies have early injuries and earlier exposures and progress. This is what it can look like. So on this side is a healthy lung, and on this side you can see there just aren't very many septations. So the surface area is significantly reduced by these big, wide open fields. There aren't those fibrotic changes that we saw earlier in the earliest of RDS and evolving lung injury, but really these big, wide open spaces that make it easy for gas trapping to occur. There are a number of definitions, and I'm not going to dwell on those because the more definitions we have, the more definitions we have. It does not change the disease. It changes how we look at it. The early definition of oxygen need at 28 days obviously doesn't mean a whole lot when you're born at 24 weeks. Supplemental oxygen need at 36 weeks post-conceptual age is still the most widely accepted definition, although defining oxygen need has been a challenge. So the NIH has put together a couple of workshops. The earliest one really looking at this talks about if you need more than 21% oxygen for 4 weeks, then who are you at 36 weeks corrected age? Are you in room air? Do you need 30%, or do you need greater than 30% and or positive pressure? Again, there isn't a clear definition in this workshop document of need. So my patient may be on 25%, someone else's patient may be on 31%, and what we're doing is we're targeting different SpO2. And we don't know what the right answer is there either, spoiler alert. Michelle Walsh and her group looked at a physiologic test for the diagnosis of BPD, trying to tap into what is an oxygen need. What happens if we do the so-called room air challenge? So your patient is on oxygen at 36 weeks. Your patient is on 30% oxygen, but what happens if you put them in room air temporarily? And can they stay in room air for 30 minutes and maintain their saturation? That's a lovely starting point at tapping into oxygen need, but we're still not getting to the meat of the matter, which is how are these lungs actually functioning? There isn't a functional definition for BPD that really has been widely applied. So although the O2 need test, or so-called room air challenge, was trying to develop a level of consistency, the diagnosis of BPD went down when it was applied across 17 neonatal network centers. So what we've done is we've changed the labeling. But if you look at those numbers, the diagnosis went from 35 to 25%, massively high numbers when you think about it. So the numbers for BPD in the community depend on what community you're in and what definitions they're using, both for oxygen requirement, for target saturations, and then specifically a BPD definition. So a very recent, last summer, executive summary of the BPD working group is again trying to get at a more refined definition of BPD. This is the one that we're trying to target. And more centers are trying to use this. If a baby's born below 32 weeks, looking at them when they are 36 weeks corrected age, do I have a baby on 21% because that baby's on 7 liters of flow? Am I trading one for the other? So this is a way to try to define BPD as grades 1, 2, 3, mild, moderate, severe. Looking at their FiO2 needs as well as their PEEP needs, if you can assume that you know the PEEP based on what the cannula flow is. Another leap. So again, the most commonly used diagnosis is an oxygen requirement at 36 weeks, but it's not consistent in all of the literature. But the real question is, what can we do to prevent it? It starts prenatally, everyone in this room knows that, and then in the first days and minutes of life. Have our tools really altered the risk? So this is a slide many of us have seen before, and it really tries to tap into all of what we know, at least as of now, may impact the infant's risk of BPD. And you can see there's a whole big segment on the left that is before we met the baby. And afterwards, those second 2/3 are once we're actually involved. And at St. Christopher's, we receive all of our babies from elsewhere. We're 100% referred population. So we're not the first third, we're not the middle third, we're only after that and whenever they choose to call us. So every center's comparison of all of these numbers is also impacted by who their population is, and that may be true for some of you in the room. So the literature quotes numbers as high as 40%. The NIH centers, as I said, were able to change their definition and change their numbers from 35 to 25. Many institutions set the bar at 15%. You feel good if you're below it. In our 2 delivery centers, we range 11 to 12%, slightly lower than we were when I was here a few years ago, but really kind of stuck in that zone. We have a very high-risk population with fairly low rates of complete prenatal care as an inner-city population. So if they have less prenatal care, they also have fewer patients that are treated with antenatal steroids. So things that we know impact these outcomes, unfortunately, we're limited by the population to an extent. And then we see the ΜΗΤΕRA's number, which is remarkably low. So kudos to what you're doing here. And for the rest of the talk, I'm going to talk about ways to try to reduce those numbers. I'm not sure you all need to listen, but maybe we need to kind of do this the other way and have you come to us and tell me what you're doing. So we can look at the tools in the toolbox. Some of the things we have been able to show with evidence, not me, but globally the neonatal community over the past 20 years, has shown what is successful. Patient-triggered or synchronized ventilation definitely has been demonstrated with clear evidence to reduce the risk. Permissive hypercapnia to reduce the risk. When I started my training many years ago, which I will not fully disclose, although you did, we were still targeting blood gases that were essentially normal for all of us. So by changing the parameters, we're obviously doing less damage to an already fragile lung. Minimally invasive ventilation across the board, yes, but in what flavor? Nasal CPAP, it really depends on the study, but I think leaning heavily toward yes. Ensure, which we heard about earlier, demonstrates less mechanical ventilation. Not a lot of data to say that it can demonstrate, there's a wire I keep tripping on, sorry, that it can demonstrate less BPD. I'm still on this. I'm not on the next slide. Oh, I tripped, I'm sorry. I was still seeing it before I left. I apologize. Less mechanical ventilation, for sure. Less BPD, it's close, but it's still equivocal. Curepop, which we heard about a little bit earlier, may not necessarily be impacting the risk of BPD. NiPPV, we'll consider that, and some other things that are coming. So the next question becomes, if we reduce the rate of BPD, and we're at a center like the ΜΗΤΕRA, looking at a rate of 4.99% over the last 5 years, how will we know if the next tool is effective? If we randomize babies to what we're currently doing and compare it to what we might want to do, we may only be able to see such a small change that it incrementally won't be able to be shown in the kind of evidence that we're all craving before we add new therapies. And so that's becoming the increasing challenge. So we're good but not great. And how do we get from good to great if it's hard to show those little bits of difference? So anecdotal evidence and small randomized control trials suggested that early CPAP could lead to a decreased incidence of BPD. It wasn't proven in 2 large randomized control trials, randomizing to CPAP or intubation at birth when patients who were 25 to 28 weeks were randomized. CPAP did not reduce the rate of BPD or death in those infants intubated at birth, and the CPAP group had a larger rate of pneumothoraces. The support study in infants 24 to 28 weeks showed that the rates of BPD or death were not different in the CPAP or intubated groups and the surfactant administration groups. So how do we know what the right thing to do is? This is another study using Ensure. It's not the original Ensure study, but a study using Ensure during CPAP, which in this population of 155 babies was shown to decrease the need for mechanical ventilation, right? You're intubating, giving surfactant, and removing the endotracheal tube. That part makes sense. There's a decrease in the AA gradient prior to surfactant, but was unable to show a difference in BPD. In the Curepop study, a randomized control trial that compared whether early prophylactic surfactant followed by CPAP compared with early selective surfactant with nasal CPAP would reduce the need for ventilation, it was able to show a reduced need for mechanical ventilation, but it was unable to show that there was a decrease in need for ventilation in the first 5 days or decreased BPD. And really, when you tease it out, it was really that it was unable to show evidence of decreasing BPD. Because the rates of BPD were so low, my suspicion is it's very hard to show that kind of an incremental difference in that type of an outcome. A follow-up meta-analysis looking at a number of studies of prophylactic and selective surfactant did conclude that it was able to decrease BPD or BPD and death as an outcome. And I believe we did see this review earlier. So when we're looking at less invasive support for our babies, let's look at it as a cohort of all types of less invasive support. There's a number of different modes and interfaces, and when you're comparing nasal CPAP, the way in which you deliver it may also be factoring into why these meta-analyses are not necessarily showing a difference, and why studies are showing one outcome, other studies are showing a different outcome. Because whether you're delivering it by prong, and there are several types, mask or specialized cannula, is it bubble CPAP given by a driver or connected to a ventilator? In many ways, the PEEP is the same at the end of the day, but the delivery may be affecting the outcomes of these babies when we're measuring them at 36 weeks corrected age. The same is also true for nasal intermittent positive pressure ventilation. We have all the same approaches to it, except for bubble, and it can be delivered with an independent driver or connected to a ventilator. In addition, there's heated high-flow nasal cannula, and we may all have different devices to do that, and some of which are homegrown and others are manufactured. And then there's also NAVA, or non-invasive NAVA, which we'll talk just a little bit about, and that might be something very encouraging to talk about at the end of my talk. So this is just a little picture of bubble CPAP for those of you who are not familiar with it. It's a pretty similar concept and sort of genius in the simplicity for countries that really can't afford ventilators. And it is widely used in countries that can't afford the sophisticated ventilators that most of us have the luxury of using. And simply placed, flow at 5 centimeters deep delivers a 5 centimeter back pressure into the nose. You'll notice there's kind of a lack of monitoring, which we're all quite used to, and that can impact what your institution is going to consider, how your institution will consider whether or not this is a usable treatment modality. So now there are companies that are manufacturing this product and putting some manometers in line just so that we all don't have to keep walking by and making sure it's really 5 centimeters deep. It hasn't slipped 6, it hasn't slid out to 3. But at the end of the day, bubble CPAP definitely works. There are a number of different interfaces. This figure shows the mask interface that can help protect our babies' nares from prolonged non-invasive or minimally invasive support. This is a specific cannula. It's a RAM cannula, and this is the only real sort of product I'll talk about. And it's a specific cannula that has been validated to interface with certain devices, not all of them, that can provide a level of PEEP similar to prongs and appear to be less invasive to parents and care providers. So when parents come to the bedside and see this, as opposed to seeing a hat with prongs in the nose and all of the Velcro tabs that our nurses do a fantastic job of sort of arts and crafts to create them staying in position, that can look much more invasive than a taped endotracheal tube to a parent. This, on the other hand, can appear to be less invasive. It's all the same in concept. These are some independent CPAP drivers that can deliver constant flow. This is a novel case report of delivering CPAP through an orotracheal tube, and it is mounted. Here we go. It's mounted into a pacifier. So if you have a baby that really takes to their pacifier, they are delivering their own CPAP by the oral route, assuming it's well positioned in the oropharynx. It's kind of a neat concept. This is one demonstration of high flow heated humidified nasal cannula, and you can see the bag for humidification. And this is a little bit of a pictorial that will describe how NAVA works. It's neurally adjusted ventilatory assist is what NAVA stands for. So we're all accustomed to patient-triggered ventilation. When we extubate or have never intubated our patients and we put them on NiPPV, there is oftentimes still a patient trigger in line. It is controversial and difficult to measure if these patients are actually triggering it or not, because none of those triggers were in essence designed to be nasally triggered by a much lower flow system. So we may or may not be fully synchronizing with our patients. In some studies, synchronized NiPPV was used and evaluated, and in other studies, there was no attempt to even synchronize, because as those of us at the bedside have all seen, synchronizing nasally is a little bit of a leap of faith. It's been very difficult to prove and to demonstrate what percentage of the time the patient's actually synchronizing. So NAVA may be an interesting alternative to that, which is not fully evaluated, least of all in its non-invasive mode. If you all go to PubMed to look this up after the conference, you will find a paucity of data. You will find very small studies. You will find safety studies showing that NAVA is as safe as CPAP or as safe as NiPPV. From an efficacy standpoint, there's been little studied. But the concept is that the CNS triggers the phrenic nerve, that excites the diaphragm to want to trigger it to contract. So in the use of a flow sensor, we're waiting for the diaphragm to contract, the chest wall to move, the lung to expand, and then the air pressure and gas flow to change to sense this assisted breath, whether it's nasal or by endotracheal tube. In this circumstance, there is an NG that is specifically designed by them to have a sensor that is at the diaphragmatic level to pick up on this diaphragmatic excitation and not wait until the gas flow changes. And in the case of nasal ventilation, like NiPPV, the gas flow may not change measurably and be able to trigger that sensor. So the concept is when the diaphragm contracts, the baby's breath is then triggered, even in a non-invasive mode. So what can non-invasive ventilation and specifically NAVA do? Well, non-invasive ventilation can do all of the things on this list. It can increase the lung volume. It can increase compliance. It can decrease airway resistance. All of these things have been shown. It can improve respiratory timing by decreasing obstructive and mixed apnea when you're looking at nasal CPAP, although that might not be different than NiPPV. Some studies have shown increased thoraco-abdominal synchrony, so is the baby taking a nice synchronized low work, low energy breath. Other studies have not even attempted to look at that. And only NAVA has been demonstrated to improve respiratory timing. That is what the studies are showing. As far as improving oxygenation, all forms are able to do that. They decrease pulmonary vascular resistance, decrease intrapulmonary shunting, increase alveolar volume, and decrease alveolar collapse. So when you're choosing among your options, many options do most of your options, right? So most of the things you're trying to do for your patient can actually be achieved, whether the choice in your unit is nasal CPAP, nasal intermittent positive pressure ventilation, or something like NAVA. When it comes to high-flow nasal cannula, again, this has been proven for all but improved respiratory timing for high-flow nasal cannula, but it really does depend on the type and the nasal interface. So let's talk just a little bit about NiPPV, because that's what we've become most accustomed to using. So there was a time when we were completely avoiding intubation whenever possible. We were intubating only to give surfactant, which we heard earlier is really revolutionized the care of neonates from a respiratory standpoint. No argument there. However, the change from nasal CPAP to NiPPV, I would say, somewhat insidious, but become a real culture shift. And I think now the data is starting to show us that maybe we made the right shift. So we'll talk briefly about the indications for use because you all are using it. Some concerns, the nomenclature, which is amazingly confusing. When you're setting it up, how do you choose settings? How do you make some transitions? What we know, what we think, unanswered questions. So the indications, well, our big indication for everything we do from a respiratory standpoint is reduction of long-term complications. That would be BPD. The goal to reduce volutrauma, reduce the highs and the lows of oxygenation, reduce hypercarbia while being in the acceptable range, lower work of breathing, ideally by being more synchronized, unloading the respiratory muscles, that's a lower labored breathing index, which is measured in the same way, increasing the spontaneous tidal volume by ideally supporting it when the baby's inhaling, reducing apnea, reducing ventilator-associated pneumonias, a metric that we track that is an increasingly infrequent event with fewer and fewer days of intubation, reducing discomfort when compared to intubation, and improving the interaction with their environment. It's much more easy for babies to be transferred in and out of their incubators or cribs and be held and cared for by their parents when compared to intubation. So some of the concerns, I think we're way past. These are complicated devices and techniques, and it's a little bit of a leap and a learning curve. I think we got past that. There have been concerns about gaseous distension of the stomach that can potentially lead to perforation. And that, unfortunately, is a true risk for any nasal delivered positive pressure. Contraindicated with airway abnormalities of the upper airway. If you have choanal atresia, cleft palate, a TEF, it would be very difficult to use a nasal level of support. Tissue breakdown of around the nasal interface, like we just alluded to, and feeding difficulties, which very likely have to do with the gaseous distension. So these are the things we never want to come in the morning and find. The tissue effects of the nasal interface. And as I said, nurses do an amazing job with minimizing this risk, but you can't eliminate the risk as long as there's something that shouldn't be there that's there. So we all hope not to see this, but unfortunately from time to time we all end up seeing it. The nomenclature, I'm going to call everything NiPPV. Intermittent breaths through nasal prongs. It can be synchronized, known as SNP-V, but again, we're not always sure if we're actually synchronizing, so many of us just call it NiPPV. It can be primary when it's done shortly after birth, either immediately after surfactant or without surfactant. Secondarily, post-extubation of a baby that does require a longer intubation period. But it's believed to be a method of augmenting nasal CPAP by combining it with some ventilator inflations. I'm gonna bypass, which ventilators can do what, because these I didn't have a chance this time to see what all you exactly have in the NICU. So I want to make sure that you're comparing sort of apples to apples. But the early studies were done with these specific devices. It's commonly believed now that any ventilator that can do CPAP and any form of a rate can do NiPPV. Whether or not it can synchronize and to what degree remains unclear. How do we set it up? Well, it kind of depends on who you ask. Although the first and second, and I will, this disclaimer, the second is my section chief. The first and second are really very much saying the same thing, just thinking at it from a different perspective. So do you add 10 or 15 to the PEEP you're already on when you decide that you need a rate on NiPPV? Or in Vineet Bhandari's study, he was looking at babies that were extubated from mechanical ventilation to NiPPV. So he had an existing peak inflating pressure that he was increasing. The PEEP ranges across the board are about the same. A rise time really only applies in the first study based on the ventilator used. The flows in each of these two first studies were when flow was set on those ventilators for those studies. Now that we're using variable flow ventilators most commonly, we're not deciding on the flow. We're deciding on the PEEP, and we're deciding on what that upper number is in NiPPV, and the device is using whatever flow it needs to deliver that. How you set a default pressure max, you can set it by the mean airway pressure, or you can set it by an upper peak. But pretty much across the board, most people are suggesting setting it up about the same way. And what happens when it's time to take the baby off NiPPV? That depends on the style of practice of your NICU. If you consider NiPPV a step in the progression, and when a baby no longer needs that rate added, that you're going to transition them to CPAP or high flow or something else, then there are some parameters published by Dr. Bhandari on when you might do that. At a rate of 15 or 20, you're probably not doing a whole lot for your patient. When your peak inflating pressures are below 17, it's unlikely that you're actually delivering a whole lot with the given leak around the cannulas. PEEP's lower than 6, FiO2's lower than 35. When to intubate? When do you say NiPPV is not working? Again, a little bit the local culture of the unit. These are the numbers published in Bhandari's study. So a pH below 7.25, a PaCO2 above 60, and I would say that would be a younger patient. A more chronic patient, we're likely to accept a higher number. If they're apneic, if they have frequent events, frequent desaturations. The take-home message, which I think we all already know, you can use blood gases to wean, but do you need them? Most of us do very infrequent lab testing when we're at a phase of non-invasive ventilation. And most of us don't believe that you need it all that often. And the win there is fewer blood draws, decreased pain and discomfort for our patients, hopefully decreased transfusions, but that's going to be tough to prove. So the NIH Chronic Lung Disease Working Group is supporting those of us who are doing fewer and fewer blood gases in our patients in a less invasive mode, which kind of, it makes sense on a lot of levels. There's going to be a baby you don't trust. There's going to be a situation. The blood gas is still the gold standard. The rules haven't changed. Having said that, we're certainly seeing that we're doing a lot less of them, and I suspect you all are as well. So the initial studies are a little bit challenging because they were all using NiPPV as a weaning strategy. All of these babies were previously mechanically ventilated. The tube was taken out. So when you look at a meta-analysis for those patients, the risk of requiring reintubation or failing that trial of extubation looks like the risk is reduced by ideally a synchronized NiPPV mode if you know that you're synchronized over CPAP. Subsequently, in also a fairly small randomized control trial, it pretty much shows the same thing, that if you're on a mode of NiPPV and you are extubated from mechanical ventilation, you are more likely to stay extubated than your counterpart that's extubated to CPAP. They were limited by their design in these early studies. One group had lower birth rates, lower enrollment weights, and fewer males. There was more RDS and less antenatal steroid use. And another lacked some adjustments of the ventilator settings after extubation to compensate for nasal delivery. So those patients were extubated from mechanical ventilation to the exact same NiPPV settings. And so then when you're comparing their failure rates and the need for reintubation, you're not exactly comparing the same patients. In a meta-analysis of 3 studies in preemies with RDS, it did decrease the need for invasive ventilation when it was done within the first 3 days of life, whether or not those patients had surfactant when compared to nasal CPAP. So it does seem like what we are seeing, that is the pendulum swinging toward NiPPV, seems very much like the way to go. This is the meta-analysis that I was referring to. And for those of you who don't look at these on a regular basis, which I can tell you until about 4 years ago was me, they are oftentimes just boiled down into this risk ratio. And the risk ratio gives you a line up the middle, and it favors one treatment over the other in an effort to compare a series of studies and say, when I add all these patients together and I compare, albeit different methodologies, is one treatment favored over the other? When the final diamond is the summative data. When the diamond's on one side, it favors that treatment. On the other side, it favors the other. If any point of that diamond touches the line, there is no difference. And you will see as we move on, I'll show you a few more of these meta-analyses with similar statistical approach. And you will see that the size of the diamond also tells you, and the shape of the diamond, how different these studies really were. So when the second 2 studies that I referred to were compared, again, it does slightly favor NiPPV over here. But if you look, the studies are completely different sizes, 21 patients and 70 patients. So that does change a little bit the way you would consider a meta-analysis. You're only comparing 2 studies, and they're 2 different sizes. When these 3 studies were evaluated, also looking at a comparison of NiPPV to nasal CPAP, but this is trying to get to the question we're all wanting to know the answer. Is it better in the long run? Does it decrease the risk of BPD? When these studies were evaluated, look at how gigantic and pulled out that diamond is. So there's really no difference when you look at all the cohort of these 3 populations. And the studies are different from each other based on the shape of the diamond, but when added together, there is no difference. So a number of individual studies have looked at this, and based on their study design, maybe more specifically tried to compare patients. And so in this study from 2009, which looked at a fair number of patients, and to be fair, I didn't add it up and give you the total, but you can see the numbers above each bar. The green bars are the patients that got nasal CPAP. The white patients got NiPPV. And you can see that in really every category, except the need for a second dose of surfactant, the groups are different. So the NiPPV patients fared better. And using the physiologic definition of BPD, the risk was reduced by using NiPPV. The likelihood of extubation failures was also lower when using NiPPV, probably attributing to all of those longer-term outcomes that we just looked at. So this is the same cohort. When randomized at 6 hours of age to either NiPPV or nasal CPAP, so this is one of the earliest groups of patients, you can see that the failure rates are different. We're at 48 hours and 72 hours. So your risk of needing to be re-intubated or intubated is very low if you are receiving NiPPV over CPAP, but they were, as per many other studies, unable to show a difference in BPD. So since most of these studies were really designed to evaluate successful extubation, and many of them just report BPD as a secondary outcome, And other studies were looking at NiPPV or apnea and reported on BPD as a secondary outcome. It was suggested that BPD rates might be decreased, but this suggestion was what I just theorized for you. If less babies are re-intubated and less days of mechanical ventilation, and less mechanical ventilation leads to BPD, less BPD, then perhaps these patients have less BPD. But none of these studies were actually ever designed to look at that question. And this is a laundry list of studies, none of which were designed to look at BPD, but looked at it as a secondary outcome. So there are 2 studies that will say that there is a difference, but again, you have to be cautious of what that difference really means if that's not the question you were intending to ask. So there are a few studies, and I apologize, this doesn't come out quite as crisply as I wanted. There are a few studies looking at BPD as an outcome. And when you do a meta-analysis of these studies, it actually just the computer doesn't quite know what to do with it because the middle study has 987 patients. So this is complicated to look at, but what you can see is in the first one and the third one, if you look on the far right, there is a decrease in BPD in the patients that are receiving NiPPV, but that's the smallest number of patients. And since there's no difference in the nearly 1,000 patients in the middle, the meta-analysis shows no difference. So since that time, there have been a few more studies. So I will walk through what we know from the most recent Cochrane review, looking at all the concerns we all have with NiPPV, yet we're all still using it. And should we be using it? What's equivocal? What should we be feeling comfortable with? So I'll start with the things that we were all really concerned about when we transitioned from nasal CPAP to NiPPV. Would it affect how we fed these babies? Would they have distended bellies? Would some of them have gastric or intestinal perforations? Would some of these patients even have necrotizing enterocolitis? So in this most recent review, there is no difference. You can see where the final bar is. In the patients that received NiPPV or nasal CPAP, neither is favored when it comes to a risk of stopping feeds due to abdominal distension, which is good. There is no difference, which is very difficult to see on here because it does slightly touch one, but there is no difference in the risk of gastric perforation and no difference in the risk of necrotizing enterocolitis. Okay, so those are temporarily off the table based on these 5 studies with a lot of patients included. So what about the risk of apnea? Are we using NiPPV to reduce apnea in our patients? Or when our patients have apnea, are we proceeding to mechanical ventilation? And what about respiratory failure leading to an escalation of support across the board? Or endotracheal reintubation. So when apnea was evaluated, and I cannot explain the line down the middle, I apologize, there is no difference between NiPPV or nasal CPAP on the outcome of apnea, which is interesting because some of the early studies thought that those intermittent breaths might remind the baby or serve as a bit of a trigger to reduce short-term apnea. Having said that, there's no difference. Now, this is the only study that was done to look at apnea specifically, but there is a second meta-analysis that shows when in 6 other studies looking at apnea as a secondary outcome that shows the exact same thing. So what happens to respiratory failure after extubation? So if you started off intubated and you got NiPPV, and these are intubated for any reason, they could be intubated for inshore, or they could be intubated for purposes of ventilating them in a shorter or longer period of time. When all patients were put together in 7 studies, and then an additional 3 that were single studies to look at the specific outcome, definitely favors NiPPV. You can see this final little dot here is on the left. So in the subtotals and in the totals, NiPPV is favored. as well as your risk of reintubation. So if you extubate a patient to NiPPV, your risk of putting that tube back in is lower than if you choose nasal CPAP when you extubate your patient, for all comers. So now let's look at chronic lung disease. Oxygen requirement at 36 weeks and the risk of pneumothorax, because that's a secondary pulmonary outcome that we are still concerned about. When you looked at chronic lung disease for all patients, there is no difference, no matter how many times studies are done to look at this. And again, it might just be that the rates of BPD are becoming so low that showing a little change in an infrequent event is increasingly difficult. However, NiPPV favors a reduced risk of pneumothorax over nasal CPAP, which is at least an advantage. And lastly, do these babies stay in the hospital longer? Are we extubating our patients or placing our patients on NiPPV, and then is that one more step in the weaning progression that is delaying their time to go home? And are these patients at increased risk for mortality? Well, when it comes to length of stay, there is no difference. And in these studies that were designed to specifically look at length of stay as an outcome, when it comes to the risk of death before discharge, definitely is favoring NiPPV, but you're favoring it only very slightly. So those of us who are using NiPPV, and the last time we all talked about this was the majority of us, it does seem like the best of our current options. But what do we do moving forward? What's the next tool in the toolbox? I think the next tool in the toolbox, and we're working with, I'm working with 2 of my colleagues and 2 of our fellows in training. We're trying to design some studies to look at synchrony on nasal CPAP versus NiPPV, well, on NiPPV rather, versus NAVA in a non-invasive mode. Are we synchronized in one way better than the other? And can we compare outcomes for both of those patient populations? Is NAVA the next big thing? Is it what the proponents are touting, or is it just one more tool in the toolbox, and do we ultimately have to truly personalize care for our patients? When we put all of our patients together, is it difficult to show a difference? And might there be some metric that we can measure in a patient to say, baby A needs nasal CPAP, baby B needs NiPPV, baby C needs NAVA? That's where I'd like to see us go, as opposed to the pendulum and the blanket decisions that is our tendency right now. But when you feel very strongly that something is going in the right direction, and all of these multi-center multi-center studies and meta-analyses are showing that one is favored over the other, even ever so slightly, it's hard not to treat your patient with that therapy. But if we tease it out and narrow it down to subgroups of patients, are we going to find a way that we can more personalize care for our patients? That would be our ultimate hope. And by using some less invasive measurements, can we ultimately get down to that question? So, what can the data tell us? Well, it can tell us there's a lot of studies, not many as maybe as many in stem cells, but we're getting there. Many of them are randomized control trials. That's great news because people are looking at this the right way. But very few of them have any functional measures of success or failure. So makes it difficult to know how can you assess your patient and determine what to give them unless you make a group decision for all comers. There's a number of endpoints and outcomes. Despite this, everyone wants to comment on reduction of BPD. It's like the hot topic to talk about, although it's difficult to show in any of these studies. And it still might be difficult to evaluate in a clinical trial. So as much as I am saying that many are commenting on this without the studies being designed that way, it's difficult to fathom a study that can be designed that way, which is why we're all in this position. So the best news, the goal of lowering BPD is being achieved. The numbers are improving in all of our nurseries, and we're going to strive for your numbers with our outborn babies. Newer therapies and heightened awareness are probably to credit. So we're all on top of this situation. This is always the worry every day in every baby. Any baby that we are supporting with any respiratory treatment at all, we are always trying to avoid that long-term complication. As I said, it may be difficult to demonstrate an improvement in a good outcome, but we're going to try, and personalizing care is ultimately the way I imagine this going over the next few decades. Thank you.